For the next 30 minutes or so, we're going to discuss the radiologist's approach to the drainage of a variety of intrathoracic air and fluid collections. First, I'm going to begin by discussing the percutaneous transcatheter drainage for pneumothorax, and this is generally in the setting of a patient who has undergone either a percutaneous biopsy by the radiologist or a transbronchial biopsy by the pulmonologist and develops a pneumothorax. Our indications for draining these pneumothoraces include any patient who has either a very large or a symptomatic pneumothorax of any size, a patient with underlying emphysema or severe obstructive lung disease with a pneumothorax is generally a patient who should be drained regardless of the size of the pneumothorax. And if we see that the patient develops progressive increase in the size of the pneumothorax or develops radiographic evidence or findings which might suggest the development of tension, those patients should have and proceed to percutaneous drainage. Here's an example of a patient on the right who is biopsied using CT guidance for a nodule mass seen here in the left lateral lung. In fact, you can see the tip of the needle actually in this lesion. This lesion turned out to be an adenocarcinoma of the lung. And as is our routine, immediately after the biopsy, we obtain an image through the thorax to make certain that the patient has not developed a pneumothorax. And as you can see here, the patient here has a small pneumothorax. The patient was asymptomatic, and we opted to just observe this patient. We routinely obtain a film at 2 hours after the biopsy, or if the patient develops symptoms. In this particular patient, the patient complained of chest pain and shortness of breath. And you can see here on the follow-up chest radiograph that there's a fairly large apical pneumothorax that has developed. And because of the patient's symptoms and because of the obvious increase in the size of the pneumothorax, we proceeded to bring the patient to fluoroscopy and perform percutaneous drainage. Here's the image of the patient with the catheter placed over the apex of the lung. You can see that the lung has almost completely re-expanded. There's still a very small left apical pneumothorax. And then the film obtained the following morning after the patient had been detached from the Pleurovac device, which shows that the lung has remained re-expanded. Our indications for percutaneous drainage of fluid collections include the following list. At the University Hospital, the predominant indication for this procedure is for the treatment and symptomatic improvement of patients who are found to have malignant pleural effusions, usually secondary to either breast or lung carcinoma. We were also not uncommonly asked to drain infected parapneumonic or postoperative fluid collections, particularly at our county hospital. On occasion, we will be asked to drain an abscess in a patient who either is not considered for surgery or even in a preoperative setting in whom the surgery is risky because of the severity of the patient's illness. On occasion, there will be a patient who has a post-traumatic hemothorax or chylothorax whom will be presented for percutaneous drainage. And then there are a number of patients that come across who have unexplained or explained transudative effusions in whom repeat thoracenteses do not seem to eradicate the effusion and whom will proceed to percutaneous drainage and perhaps chemical pleurodesis. The contraindications to this procedure are really limited. There are no absolute contraindications to the performance of this procedure, but in patients who have underlying coagulopathy, whether it be due to thrombocytopenia or liver disease, which is not uncommon in our county population, we tend to try to correct these factors prior to undertaking the procedure. Similarly, if we have a patient who has a lung abscess which is not adjacent to the pleural surface, we are not terribly comfortable in draining these percutaneously because of the concern that the patient may develop a bronchopleural fistula with an empyema, since when there is lung around the periphery of a lung abscess, it suggests that the viscera and pleural pleura are not in symphysis. In terms of the imaging for drainage, we have obviously available to us a number of different modalities which we use depending upon the clinical situation. Nowadays, we probably use ultrasound for the majority of our procedures. It's obviously very readily available to most radiologists. It obviously requires no ionizing radiation. It's portable, and it is found to be very useful for those patients who have very large free-flowing pleural effusions or large costal pleural collections where we can obtain an acoustic window in order to guide the drainage procedure. Real-time visualization is also somewhat helpful so that we can actually watch the pathway that our guide wires, dilators, and drainage catheters take during the procedure. Here's an example of an unfortunate woman who has bilateral malignant pleural effusions related to metastatic cervical carcinoma, a very large right and a smaller left pleural effusion. This patient was quite symptomatic, and the diagnosis of a malignant effusion had been made via a diagnostic thoracentesis. We brought the patient to fluoroscopy and placed the patient in the sitting or upright position, and with ultrasound you can easily see the diaphragm here adjacent to the left lower lobe of the lung. Here's the chest wall posteriorly, and here's the underlying collapsed lung, and you can see very obviously that there's a very large dependent fluid collection in the right and also in the left lower hemithorax. Using the ultrasound guidance and marking the patient, as you can see here, these strips of echolucent areas represent a metallic clip that we use to localize the proper needle entry site. We then place the catheters percutaneously, and here's a follow-up image of the patient showing that the right pleural effusion, although not completely drained, has diminished significantly, and that there's a very minimal or absent left pleural effusion. Now, computer tomography is really best when you're dealing with a very complex process on the chest radiograph, and you're not quite clear whether the process you're dealing with is either a purely pleural or parenchymal or perhaps a mixed pleural parenchymal process. And so we will use these in patients whose radiographs are equivocal as to exactly whether we're dealing with one process or the other. The other advantages are that obviously it provides a visualization of the entire pleural space, which is important if we're going to try and eradicate any pockets of fluid which may not be obvious from chest radiography or from ultrasound. It also provides a direct visualization of the pathway that our biopsy, or rather our drainage catheter is going to take, and this is important if we are to avoid transgressing very vital structures and vascular structures. And then obviously we can immediately assess the adequacy of the drainage by placing the patient back into the gantry and scanning to see if we have adequately drained the pleural fluid collection, and if not, we can immediately place additional catheters or reposition the catheter that we have placed in order to completely evacuate the collection. Here's an example of a patient who presented with really nonspecific pulmonary symptoms who has a very obvious large air fluid level in the right hemithorax. And by looking at this, it wasn't exactly clear to us whether this was a pleural or parenchymal or mixed pleural parenchymal process. You can also see a small cavitary lesion in the left lung. And so we utilized CT here both for diagnosis as well as to guide the procedure that we were almost certain we would have to perform in this patient. And here's the CT scan on this patient, and you can see the patient has a very large fluid collection with what we would term a split pleural sign, indicating that this is a very large air fluid collection in the right pleural space. You'll notice how it conforms to the chest wall, how it causes compressive or passive atelectasis of the underlying lung, and lower down, similar findings, a large air fluid level in what represents a hydropneumo or pyoneumothorax in this patient. So once we have seen this, we simply turn the patient on his or her side and using a trocar technique, place a catheter into this fluid collection and then attach the patient to a Pleurovac device for drainage. Here's a follow-up scan on this very same patient, and the catheter is difficult to see on this image, but it lies here in the dependent part of the pleural space, and you can actually see in this particular patient that the pleural process is actually due to a septic embolus in this IV drug abuser that has ruptured into the pleural space and given the patient a bronchopleural fistula. And here you can see a PA radiograph of the chest in the same patient just 2 months after the procedure, and you'd have a hard time knowing that this patient has such a large pleural process just 2 months ago. Now, thoracoscopy is still utilized for these procedures. It's obviously something which is readily available to us, fairly easy to use, and provides us, most importantly, as does real-time ultrasound, with the ability to visualize the pathway of our needles, guide wires, dilators, and catheters. It doesn't have the same space constraints that one finds in the CT area, where you're dealing with a very narrow table and where it's quite difficult to try and maintain a sterile field. So we often use fluoroscopy if we feel that we're going to need a lot of room, a lot of space, and when we can easily see the fluid collection that we're draining on fluoroscopy. In this situation, the patient is placed right side down for this loculated left posterior pleural fluid collection, which is very easily seen. And using a trocar technique again, place a pigtail catheter into the collection, aspirate the infected fluid, which in this case turned out to be a staphylococcal empyema, and here's the follow-up CT scan obtained 8 days later with the pigtail catheter in the pleural space. You can see a very small residual pleural fluid collection, some hypertrophy of the extrapleural fat, and a little bit of adjacent collapse of the lower lobe. Now, the technique of percutaneous drainage varies again from institution to institution and from one radiologist to another. The most important thing is probably to choose the imaging guidance that you feel most comfortable with or that is available to you in order to perform the procedure. What we generally do with our infected or suspected infected fluid collections is we perform a diagnostic aspiration, usually using either an 18 or 19 gauge needle, and then examine the fluid to see if it is obviously infected. If we're dealing with gross pus, then I don't think there's much question that we have to go and proceed to a percutaneous or other type of drainage procedure. If there's a question as to whether the fluid collection is infected or is indeed an empyema, then we can always send the material for the appropriate gram stains or cultures or chemistries, and then either directly proceed to drainage once those results are back, or bring the patient back to the radiology area after it's determined that the patient requires percutaneous drainage. The choices of using either a trocar or a Seldinger technique, again, varies from person to person. Some people feel rather uncomfortable in placing a harpoon through the chest wall in fear of lacerating the underlying lung. I think when carefully done with very large peripheral collections, it's not really of much concern. A lot of people still use the progressive Seldinger technique when you're dealing with a collection which is in a very difficult position to access, or when you're dealing with a small collection and you're concerned about perforating through the collection. We obviously choose the appropriate catheter and the appropriate diameter of catheter based upon what type of fluid we're draining and the size of the collection. And we always want to place our catheter in a dependent location, because the hallmark or the important concept is that you must place the catheter in the dependent location in order to eradicate the infected fluid from the chest. Here's an example of a patient who has a pneumothorax on the right, which developed after a transbronchial biopsy in this patient who has idiopathic pulmonary fibrosis. The patient has very severe underlying lung disease, and even with this small right pneumothorax, the patient was significantly short of breath. The patient was brought to the radiology area, and using a trocar technique, the patient was placed with the left side down, and you can see the pneumothorax much more easily when you place the non-dependent side up. And you can see the upper lobe and lower lobe here, and you can actually watch under fluoroscopy as you place your trocar catheter into the pleural space. You remove your stylet, and then you simply aspirate some air to make certain that you're in the pleural space, as we've done here. Then you simply, holding your cannula still, slide the catheter gradually off of the cannula, and slide it progressively over the apex of the lung until it lies in the very lung apex, and then attach the catheter to a suction device to evacuate the air. When we are performing a drainage and we want to use a Seldinger technique, we use these materials seen here on these slides. Here is a typical Potts-Cournand angiography needle, which we commonly use to gain access to the pleural fluid collection. We use a floppy-tipped, long-length tapered 15-centimeter guide wire, and then we progressively dilate the tract in 2 French increments until we've reached the diameter of catheter that we want to place. And usually the catheter is some type of a retention catheter, either a pigtail cope-type nephrostomy catheter, as you see here, or more recently they have developed, or Drs. Mueller and Van Sonnenberg have developed specific empyema drainage catheters which have a gradual retention-type curve to their tip, which are specifically meant for empyema and abscess drainage. Here's an example of a Mueller catheter, which is a catheter which comes anywhere from 10 to 16 French in diameter. You can see here this is the stiffening cannula, and this is the sharp-tipped stylet, and this is a catheter that is meant to be placed using a trocar technique. Once the catheter is in the fluid collection or in the abscess, it retains this curved shape to it, and there are fairly large multiple side holes in the tip of this catheter in order to drain fairly thick fluid collections. After we have placed our catheters, it's very important that we fix the catheters in position in order to avoid their inadvertent removal. We attempt to then aspirate the fluid or air collection completely by hand until we get resistance or the patient develops pleuric-type pain. We then almost always attach our catheters to a Pleurovac suction device in order to evacuate the remainder of the fluid or air in the chest. It's very important to realize that although we are radiologists used to living our existence in the radiology department, that you really do need to go on daily rounds to see these patients and assess that their catheters are in the proper position, that they're functioning properly, checking to make sure that the patients are on the appropriate antibiotics, that the catheters are flushed at least once or twice a day to maintain patency, and to make sure that there's no change in the character of the fluid that might suggest either superinfection of a sterile collection or perhaps a laceration of lung, as might be evidenced by a bronchopleural fistula that develops, or the development of bloody discharge from the tube, which might suggest that one has lacerated either the lung or an intercostal vessel. I don't advocate anymore that we do daily chest radiographs on these patients. I think that the patients are showing good clinical response and the drainage from the tubes seems to be adequate, that it really isn't necessary to get daily chest radiographs to assess the drainage. But generally, we will follow with PA and lateral chest radiographs in the department until we're at a point where we feel it's appropriate to remove the catheters. Most of these patients should probably have a CT scan at least 5 or 7 days after their drainage procedures in order to make sure that one has not missed an area of undrained either infection or fluid that might require additional catheters or might require the installation of some lytic therapy into the pleural space. Here's an example of the fixation device that we use at the University and County Hospital. This is a regular old stomahesis device which is placed over the catheter onto the patient. We then sew through the tape around the catheter and through the ring of the stomahesis so that in fact the catheter is really not sewn to the patient but is really sewn to the stomahesis device itself. This catheter, in this case a cope nephrostomy catheter, is attached then to a Pleurovac suction device which is placed by the patient's bedside and put to underwater suction, usually at minus 20 centimeters of water. The time to remove these catheters is generally when the following things have happened. The patient has defervesced and no longer has any fever, when the white blood cell count has returned to normal and there's no evidence of a leftward shift, when the drainage through the catheter has diminished to approximately less than 25 cc's over a 24-hour period, and when radiography, either chest films or ultrasound or CT or whatever you might want to use, has shown that the fluid collection has resolved. In the patients who have malignant effusions or who have recurrent transudative effusions that are going to require chemical pleurodesis, the factors or the things that we look for in order to determine what the proper timing is for chemical pleurodesis, we want to see that the chest radiograph or CT shows that there is either minimal or no residual pleural fluid remaining in the lung and that the underlying lung has expanded to obliterate the pleural space. Because if this has not occurred, the chances of us being successful with our chemical pleurodesis is really not very good. The other factor that we look at and which has been looked at in a number of surgical studies is that if the patients have an output of greater than 100 cc's over a 24-hour period with a malignant effusion, that portends a poor result from chemical pleurodesis. So if the patient is having a very high output, one should not attempt percutaneous pleurodesis. Here's a patient who has a metastatic nasopharyngeal carcinoma to the left pleural space. You can see the obvious left pleural fluid collection here. And here is the patient with pigtail catheter seen down here in the very dependent part of the pleural space. You can see the fluid collection has been adequately evacuated. The drainage at this point was less than 10 cc's over a 24-hour period. And at this point, the clinicians instilled 500 milligrams of doxycycline. As you may or may not know, tetracycline is no longer commercially available for chemical pleurodesis, so most clinicians are now going to be moving towards using either doxycycline or bleomycin for this procedure. And here you see after the catheter is removed, 2 weeks later the patient has no reaccumulation of the malignant effusion. What do you do when your procedure has failed? And it's known in the surgical literature that tube thoracostomy with very large bore tubes clearly fails at least 25 or 30% of the time. So it's not an uncommon situation that we would expect our smaller catheters to fail as well. And I think it's important to realize what factors you need to look at to determine whether your failure is due to factors that you may be able to control versus those which really can't control. It may well be that the catheter that you've placed has not been adequately checked, and it may not lie in a dependent or in an optimal position to drain the fluid collection, and it may need to be repositioned. It may be that we have additional undrained locules of fluid that are obvious either on chest films or on CT, which require the placement of additional catheters. It may be that our fluid collection is so thick and viscous that the small catheter that we have placed, despite our rigorous flushing, is really not adequate to drain such a thick fluid collection. It may be, and this seems to be increasing in indication, that we need to instill some lytic therapy, most commonly urokinase, but in some situations streptokinase, in order to break up the fibrinous adhesions that one sees in a pleural fluid collection that has been present for more than 1 week to 2 weeks in duration. And then finally, there are a number of patients who are going to require some type of either open thoracostomy procedure with the resection of a rib. Some people may even require an LOS or flap for long-term open drainage of infected collections, or most radically, there are patients, particularly those who have post-operative or post-traumatic infected collections, that might require a formal thoracotomy with stripping of the lung and decortication, something that we'd like to avoid but is inevitable in a certain percentage of these patients. Here's an example of a patient in whom a catheter was placed for a dependent left posterior pleural fluid collection, and the patient initially did very well, but fever and white blood cell count elevation returned, and we brought the patient to CT to try to determine why we had not adequately drained the collection. And it wasn't obvious from the chest films what the problem was, but when we brought the patient to CT, we instilled some contrast through the catheter, and you can see that the fluid collection that the catheter is within seems to be communicating with the catheter very well, but that there is a fairly large subpulmonic fluid collection that does not appear to be communicating with the more posterior collection. Just to make certain that was the case, we put the patient in the prone position, and you can see that the subpulmonic fluid collection does not appear to communicate with the more posterior fluid collection, even though on this image it would appear that they are directly contiguous and that they might communicate. What we did in this situation is, with the patient in the decubitus position, we used a trocar catheter to place into the subpulmonic collection. You can see the catheter here with its pigtail tip in this fluid collection. And we injected contrast here, which showed that this was obviously a very complex-looking fluid collection, multiple septations, number of air fluid levels, and you can see, although this is directly contiguous to this collection, it does not directly communicate with the more posterior collection. In order to try to drain the posterior collection more adequately, because we were concerned that the position of this pigtail tip was perhaps not in the most dependent part of that pleural fluid collection, and that the adhesions or the apposition of both visceral and parietal pleura might preclude adequate drainage of the more posterior locule here, we decided, while on the CT table, to place a guide wire through the catheter and then put the guide wire into the more dependent locule posteriorly. Here you see the guide wire in the very deep portion of the costophrenic sulcus, and then simply slid a larger new catheter into the more dependent fluid collection posteriorly. This induced an increase in drainage from both catheters, and the patient was able to be discharged about 5 days after this procedure. So in this situation, it's important to realize that one might need to reposition catheters or place additional catheters when one has failed with the initial attempt to drain infected collections percutaneously. Here's another example of a patient who had a persistent, very large fluid collection at the left lung base. It's very difficult to see on this image, but there's a large surgical chest tube that's placed all the way up in the upper part of the thorax here. And the patient was having persistent fever, and so we brought the patient to computed tomography and tried to drain this collection. Here you can see a catheter which is in this very complex-looking fluid collection at the left lung base. Here you see a fluoroscopic image of the same catheter. This catheter put out about 50 or 75 cc's, but the patient really didn't effervesce, and the chest radiograph didn't really improve. And so we decided that we would try to place a much larger catheter in and attempt to administer some lytic therapy, since this fluid collection was very bloody in this patient who had had trauma and developed a post-traumatic hemothorax which became infected. Here you can see what we've done is placed a guide wire and a series of dilators through the chest wall, progressively dilating the tract up until we get to the point where we have what is, in essence, a very large tube, similar to what the surgeons would put in, but we've done this percutaneously under imaging guidance so that we know exactly where our catheter is going, and we use the same track that our indwelling catheter was in. And then through this catheter, we administered 3 doses of urokinase, 75,000 units over a 24-hour period. Here you can see the CT image immediately after the catheter is placed, the catheter in the left lower thorax with a lot of fluid and blood adjacent to it. And here's an image obtained after the chest tube was removed about 7 or 8 days later, in which you can see there's still some residual collapse, but that we have fairly nicely evacuated most of the blood and infected fluid from the pleural space. The success rate for percutaneous drainage for pneumothorax is generally on the order of 80 to 100% in most of the literature that appears in the radiology journals. It turns out that most of the failures of this technique for the treatment of pneumothorax are in patients who are found to have very large or persistent bronchopleural fistulas, something that we see not too uncommonly at the county hospital when we deal with patients such as this, where there's a very severe bilateral pneumonia due to pneumocystis carinii. And the patient, as you can see here, has an air cyst or a loculated pneumothorax or pneumomediastinum, which is contained within the region of the inferior pulmonary ligament. The patient developed a spontaneous pneumothorax, and we placed one of our small catheters, which is rather difficult to see, into the pneumothorax in an attempt to drain the air collection. However, the patient deteriorated clinically, developed worsening ARDS, and required intubation with mechanical ventilation. And once that occurred, the patient suddenly developed hypotension, absent breath sounds on the right, and you can pretty easily appreciate that although our catheter is in position, the patient has developed radiographic signs of a tension pneumothorax. At this point, the surgeons became involved and decided to put one of their large chest tubes in, which you can see here. But you can still appreciate that there's a small pneumothorax here. We still have this air collection more inferiorly, and the patient has developed what appears to be a pneumomediastinum on the left. And here you see an image obtained 2 days later in which the pneumothorax is persistent. There was a very large air leak from the surgical chest tube, and the patient has an increasing pneumomediastinum and perhaps a medial pneumothorax. The patient succumbed to his illness several hours after this film was obtained. So in most of the patients who have failed this procedure for pneumothorax drainage, these patients don't tend to do well even with larger surgically placed catheters. When one is talking about the drainage of fluid collections, the success rate is somewhere on the order of 80 to 90% in most series. Those that have failed are generally due to the following list of things. Either the collection has been around for a very long time, and so the lung cannot re-expand and the pleural space cannot be obliterated. There are multiple loculations which simply are not amenable to percutaneous drainage. One is dealing with a very bloody or fibrinous fluid collection, again, which is not amenable to percutaneous drainage. One has severe pulmonary or pleural fibrosis, which precludes the lung from expanding and obliterating the pleural space. And the catheter perhaps gets plugged regardless or despite our attempts to keep it patent by flushing it twice a day. The complications from this procedure are generally almost around 0% in most series. Usually a small pneumothorax or a little bleeding occurs. One might see re-expansion pulmonary edema when you evacuate a large air or fluid collection too rapidly, but this has not been a very common problem in our experience. Just to close with, I want to show you one case which shows you what is possible in this day and age with the availability of imaging and with these percutaneous techniques. Here's a patient who actually has a problem a little bit different than the cases that I've shown you. This is a young man with a long history of sarcoidosis who developed what most of you would recognize as a fairly characteristic mass with an air crescent surrounding it, which represents an intracavitary aspergilloma in this patient who had very severe bullous sarcoid. The patient developed very massive and recurrent hemoptysis from this aspergilloma, which was treated initially with percutaneous transarterial bronchial embolization, but the patient continued to bleed despite an adequate result angiographically. And the patient was not considered as a surgical candidate because of the very severe parenchymal and pleural fibrosis that exists in this patient who had had a resection of the left upper lobe for a similar problem several years previously. Here you can see on the CT image this mass within this left upper lobe, bulla or cavity, and this patient really had no other options and was really left by the surgical and medical services to flounder and await a fatal episode of hemoptysis. What we chose to do, because we really didn't have any other options, was bring the patient to CT And using the CT image to go through an area of pleural thickening, we placed a needle into the cavity, and then using fluoroscopy, we placed a pigtail catheter into the cavity surrounding the aspergilloma, which you can see right here, going through the pleural chest wall surface and surrounding the mycetoma. And here you can see after 14 days of intracavitary amphotericin B, the patient had no further hemoptysis, and you can see that the cavity is now empty and the aspergilloma has been evacuated via the catheter. And if you look at some of the crude coronal reconstruction, here you can see the mass within the cavity with the catheter around it before the amphotericin. Here you can see the same patient with a very large cavity after the aspergilloma has been drained. Well, I hope that I've been able to provide some type of an overview as to the types of air and fluid collections that the radiologist might encounter in his or her daily practice. Thank you very much.